Okay, here we are at week 4, and our discussion today is going to be regarding immunity, inflammatory responses, immunizations, and hypersensitivity reactions. I will try to point out some key things to really comprehend and know because some of this material is a little bit confusing. It is just for normally anyone. So again, I will try to point some stuff out that would be good for you to review and to maybe read in the book also to give yourself an added bonus of really understanding this. So we're going to start with immunity. Immunity is the body's ability to destroy pathogens and prevent infection. It provides protection against invading organisms. This is what keeps us healthy, is if we have a good immune system. There are different immune responses, and if you have an immune response that is immunocompetent, what that means is the system responds appropriately and destroys antigens. It is the ability to recognize itself and non-self. So if you have an autoimmune disease, they are not able to do this. They are not immunocompetent. Immunocompetent also depends on tolerance. It's the ability to selectively attack some antigens and ignore preserved body tissues and/or cells. So an immunocompetent immune response is a good one that we have, and it is one when it attacks the correct antigens to keep us healthy. Immunocompromised, you're going to go over in 281, which is your third semester. But immunocompromised is a reduction of immune function endangering the patient's health. And again, they go into more detail with that in third semester. And then we have hypersensitivity reactions. And a hypersensitivity reaction is an immune system overreacts to the antigen, causing harm to the patient. Sometimes you will develop a tolerance to this. So this is something else to be aware of. There are 3 processes that protect us. So to be immunocompetent, you need all 3 of these. Okay, so it's kind of good to understand that you do need to have the inflammatory response, which is a natural inflammatory immunity, a cell-mediated immunity, which is at the cellular level, and an antibody-mediated immunity, which is the humoral level. These processes are interdependent on many levels, and they trigger each other. So when they trigger each other, that means that if we have all 3 of them, we are immunocompetent, and again, that is a good thing. That is what we want. The inflammatory response is a natural immunity. Okay, this provides protection against invading organisms along with immunity. So if you have tissue damage caused by a wound or by an invasion by a pathogenic microorganism, this will induce a complex sequence of events collectively known as the inflammatory response. The goal of the inflammatory response is to wall off your infection. It will contain it. It will dilute and destroy offending organisms. It also cleans up the site and excavates the site of inflammation and ultimately will produce healing. So this is a very good thing that happens many times. If you look at this picture here, this boy, he fell down and skinned his knee. Your tissue will recognize that there is some microorganisms in it. An inflammatory response will go around it. It will wall it off, and then it will dilute and destroy the offending organisms in that tissue where that scraped knee is. It will also clean it up, and it will also excavate the site of inflammation. So it's pulling out all those microorganisms, and it's getting rid of them. It's eating them up. You know, there's several different ways it does this, and then eventually it does produce healing. There are different stages of inflammation, and these stages are very predictable. So stage 1 is your vascular stage. This is an immediate response by the body. The injured tissue causes a histamine release, which stimulates vasodilation. So what is vasodilation? This is when you have the increased blood flow. If you have increased blood flow to an area that is inflammation, you will see redness and warmth to that area. It will also increase capillary permeability. Okay, so when you have an increased capillary permeability, this will leak fluid into the tissues, and this is where you will see sometimes the edema, the swelling of an area where an injury had occurred. And again, that usually is because of the increased capillary permeability. Macrophages, which are also considered monocytes, and neutrophils flood to the area, and they're phagocytic. Phagocytic means that they are going to go and consume them, and they are going to essentially eat those microorganisms and take care of them so they are not spread throughout the body. The macrophages also stimulate antibody-mediated or humoral and cell-mediated immunity. And that'll make a little more sense in a bit when we talk more about this. It is important, do know like what basophils do and eosinophils. Those do play important roles also. The basophils stimulate both the general inflammation and inflammation of allergy and hypersensitivity reactions. So if we don't have that, we don't have our basophils, we're not going to be able to identify that inflammation immediately. And then eosinophils increase in allergic reactions and parasitic invasions. And again, those are also very important. So if you have someone that has an allergic reaction, the eosinophils are called in, and that will help with the inflammation to control the response. So again, know what your macrophages, your basophils, and eosinophils do with these different roles. Stage 2 is cellular exudate. What is exudate? You guys probably already know, but it's a result of dead white blood cells. It's fluid from a damaged cells and necrotic tissue. It could be purulent drainage. So when you have got a scrape, like that boy that had a scrape on his knee, once it has the initial stage, the vascular stage of inflammation, then it will start ridding itself of those cells because the macrophages is taking care of it. And how do they get rid of it? A lot of times it's that purulent drainage that you'll see. You'll see that pus that's coming out. Okay, that is stage 2 of your inflammatory stages. Stage 3 is tissue repair. We will go over that in wounds, but just know the cell tissue divides or scar tissue results, depending on how big the wound was and how long it took for that wound to heal. So inflammation can be either acute or chronic. This slide is regarding the acute inflammation, which is immediate, right? Acute, immediate, pretty much they go hand in hand. Acute inflammation produces local and systemic manifestations. Signs and symptoms of acute inflammation depend on your location and your extent of injury. Does that make sense? I mean, if you have a huge injury and where it's at, it'll depend on how much of these signs and symptoms you will see. Do know, though, that the 5 cardinal signs of inflammation include warmth or heat, redness, swelling or edema, pain, and it could be loss of function. What do I mean by loss of function? Let's say you got a brand new set of knives for your kitchen and you're so excited to cook something and you're chopping away, it's so sharp, you suddenly chop into one of your fingers. Believe me, I see it all the time in the ED. So you're going to have the warmth, right? It's going to be hot, it could be warm to touch. You're going to see swelling to the area. It's going to be red. It's going to be very painful. And the loss of function, that person usually is not able to use that finger, until it heals correctly. If they still have a finger, hopefully they did not cut the whole thing off. But anyway, so loss of function, depends on the type of injury and where it's at. Other acute inflammation signs, symptoms could be fever. Okay, be aware that your older patients may not have a fever due to a decreased immune function, so you must assess for other signs. The elderly, their immune functions don't work as well as when we're younger, so many times that anti-inflammatory response that kicks in does not produce a fever right away. So don't just assume if an elderly patient doesn't have a fever that they don't have some sort of acute inflammation going on. You need to look at these other signs and symptoms. You may also see tachycardia. You can see enlarged lymph nodes, and you can also see cellulitis to an area if it's large enough. Okay. Chronic inflammation is an ongoing response So if the agent causing acute inflammation is not removed, it may progress into the chronic stage. This chronic stage can last for weeks, it can last for months, it can even last for years, depending on the type of injury that had happened. Agents that produce chronic inflammation include irritant non-living foreign material. What is irritant non-living foreign material? What does that mean? This cannot be removed by enzymatic breakdown or phagocytosis. So those eosinophils, those basophils, those phagocytes that we're talking about, none of this stuff can break it down because it is a non-living foreign material, like a wood splinter. You know, someone gets a splinter deep into their finger and they can't remove it. Eventually they're going to have chronic inflammation to the area. It could be a surgical prosthesis or a suture, like one of the sutures that are done that are underneath the skin. They're eventually supposed to dissolve and the body's supposed to absorb it. Sometimes it does not. Or if you have a suture that is supposed to be removed in 10 days, I'll see this sometimes, and someone will come back a month later. Well, guess what? Where that suture was now, it's red, it's inflamed. It's more of a chronic response because it cannot break that area down, so it's not going to get better. We also have autoimmune diseases that can cause chronic inflammation. An example of this is lupus. Okay, this is a stimulus to chronic inflammation, which may be a normal tissue component, and it's the disease process is a response to the body's own tissue. So unfortunately, it's fighting itself, and it's fighting the body's good tissue. So it could be an autoimmune disease, or it could be an infectious organism. An infectious organism that you do often see in the hospital is MRSA, and that can cause chronic inflammation. So treatment, you know, how do we get these patients with inflammation better? You want to focus on promoting the healing. Okay, so what we need to do is we need to give them rest, have them drink fluids, keep them hydrated so that the cells can regenerate and it can attack this inflammation and take control of it appropriately. Nutrition is huge. You want to have a well-balanced diet with your protein, carbs, vitamins, zinc will help. Protein malnutrition. 50% of your general surgery patients will experience moderate to severe protein malnutrition. A normal albumin is 3.5 to 5. And then if there is protein malnutrition, it will make phagocytes ineffective. So a little bit about the phagocytes with the patho. If you have inflammation, it causes catabolism, where the body tissues are broken down, and you need anabolism, where the tissues are built up. Protein intake promotes anabolism, which includes your tissue healing, production of antibodies, and white blood cells. So protein is very important in your body, and it is very important that they're getting adequate protein for nutrition. Medications. What medications can we take that will help with inflammation? Anti-inflammatories and analgesics. So your salicylates, your NSAIDs, corticosteroids may be given for acute inflammation if unrelieved by aspirin or an NSAID. You usually will try to avoid them because they do suppress the immune response and immunity response. So healing may be decreased. An example where we give a corticosteroid is somebody that is having an acute asthma attack. They need those steroids initially to help decrease that inflammation, where an NSAID or a salicylate would not do that type of thing. So you may give like a corticosteroid for an acute asthma attack. Antibiotics. Obviously, if there's an infection, we will want to treat with antibiotics, but we usually will do a culture first. So remember, like I was saying, when you saw that purulent drainage, when you see purulent drainage on something, we usually want to get a culture of it. And many times it'll just be like one of those cotton swabs that'll stick into one of the lab tubes, the plastic lab tubes that are sent off to the lab. But just check with the doctor first before you start the antibiotics if they want to culture the wound. So that way we can make sure whatever antibiotic they are on is working effectively for them. And then, where am I at here? We got the antibiotics and wound care. We'll go over later. That's in a couple weeks. So enough information with this. This here is just your immune system components. This is your leukocytes, which are also part of your white blood cells that's produced in your bone marrow. From this, it produces your granulocytes, your monocytes, and your lymphocytes. The lymphocytes will then, in turn, produce your B cells, T cells, and your natural killer cells, aka NK cells. So this is just kind of a graph on how the leukocytes are broken down into the different system components that help your immune function. So cell-mediated immunity, or cellular immunity, this is in your GI tract, usually contains 80% of your immune components. You are your GI tract, okay? So it involves T lymphocytes and natural killer cells. The T cells are activated by phagocytosis, and it causes a chemical destruction of the foreign invader. It will invade and foreign products such as fungus, parasites, viruses, cancer, implants. All these different types of things will make the T cell activation, alert it and cause phagocytosis to the area. Your three most important T cells are your helper T cells, also known as CD4+. Your helper T cells start the immune response, and the main cells are attacked. These main cells are attacked by HIV. You're going to learn more about HIV in third semester. You also have your suppressor T cells, which is CD8+. Suppressor T cells slow or stop the immune response once the antigen has been destroyed. Okay. It also will prevent autoimmune disorders with the suppressor T cells. Cytotoxic T cells, which is a subclass of CD8s, control parasitic infections like viruses and protozoa, and they're more specific than natural killer T cells. So these really are going to go and focus again on those parasitic infection. It's kind of good to have a general idea about this. You don't need to memorize every single thing as far as what each of these do, but just kind of know hand in hand, these T cells do play a big response in the immune function. Your natural killer cells, which is CD16+, they're surveyors. They are looking for viruses and malignant cells and any foreign invader, and they are out to get them. So those NK cells, they mean business if they see any of these going on. Here's just some slides. I don't know if this helps or makes you more confused, but helper T cells call in your killer T cells and macrophages to fight infection. Okay, so that's what your helper T cells are doing. And then your helper T cells also activate B cells. Your B cells do produce Ig antibodies, which we'll be going over in a minute. If you kind of remember back to your pathophys, hopefully this is kind of a review of this. And then the suppressor T cells tell the B cells when the body can stop making antibodies. Okay, suppressor T cells are very important because if we continue to have the antibodies response, your body's going to have a constant inflammation going on. Okay, so at some point, enough is enough. That inflammatory response needs to stop because it has already controlled the area and is taking care of it. If it continues, you could kind of have an autoimmune response possibly with this. So that's why suppressor T cells are important. Is they're telling, whoa, okay, B cells, we're good. We don't need any more antibodies to the area. Okay, antibody-mediated immunity. This is also known as humoral immunity. These are your B cells. It includes B lymphocytes. So just really know that the B cells, the primary mediated immunity, it's released from the bone marrow. So your bone marrow plays an important role in this, especially for these B cells. It's activated by the T cells and phagocytosis. So this is when there already is some inflammation going on. And then some B cells change into memory cells. Why is this important? It's important because it will quickly recognize a foreign antigen to which the body has previously been exposed to. Okay, so that way it can help fight that inflammation better. It provides acquired immunity later against diseases. Okay, so think about like, I'm thinking if you have like your chicken pox, you guys are probably all young, so you probably have the vaccine for it. But if you're exposed to chicken pox once, your body will have these memory cells that will provide an acquired immunity later against that same disease. Some B cells change into plasma cells that produce antibodies, immunoglobulins, and gamma globulins. The antibodies are the important thing here. Each antibody produced is specific for only one antigen, and it attaches it to marking it for destruction. So there's different classes of antibodies, and I could probably hear you groaning right now, but do you guys remember IgG, IgM, IgA, all these different antibodies? Well, we're going to review them right now. Okay, so antibody classes. Unfortunately, or fortunately, if you're very positive about this, is something that you should kind of understand. Okay, your IgA antibodies is the highest concentration in secretions of mucous membranes, and it prevents infections in your upper and lower respiratory tract and your GI tract. Okay, so IgA is the main antibody that focuses on this. IgD is a low blood concentration in conjunction with IgM. And then your IgE is an antibody-mediated hypersensitivity reaction. That is your IgE antibody. IgG comprises of the majority of your circulating antibodies and is heavily expressed on the second and subsequent exposures to antigens to provide sustained long-term immunity. Okay, that is your IgG. And your IgM is the first antibody formed by a newly sensitized B lymphocyte plasma cell. That is IgM. So please read this in the book, look at these slides, and just try to commit them to memory, because this is something you may not need to know now. It may be on the final, but it is just good that your antibody classes, at least you have a good understanding of. What else is important to know is the 7 steps of antibody-mediated immunity. Okay, there's 7 steps here. So you've got invasion. Once it's invaded, they've got the antigen recognition. And then the antibodies become sensitized. The antibody will produce and release the immunity. And the antibody-antigen binding goes on. Your antibody binding actions, and then you get your sustained immunity. Okay, so this is kind of a cascading effect, but you do need all of these 7 steps to have antibody-mediated immunity. This you don't have to memorize, but this again is your acquired immunity from your lymphocytes. So you can see how it divides into your cell-mediated immunity and your antibody-mediated immunity, and then where you go from the T cells or the B cells. And this, hopefully you can just kind of, looking at this picture helps kind of bring it all together once you listen to this and read it in a book, and then look, and you can kind of see the correlation of these. So acquiring immunity, ways to get the above immunity that we had just spoken about. You want to enhance your immunity by a good diet. So you want to encourage omega-3 fatty acids, probiotics, lower sugar intake. Sleep is huge. How's your guys' immune system? I'm sure you haven't been getting much sleep lately, and as nursing students, unfortunately, sometimes you may have a decreased immune system because of the fact that you don't get enough sleep. They usually recommend at least 7 hours of sleep a night. I wish I got that every night, but again, to enhance your immunity, sleep is essential, and then your diet. Acquiring immunity, we've got natural or adaptive. Natural immunity is also known as innate immunity. So natural barriers to infection or foreign substances. So there may be like gender. So like the male urethra actually helps prevent urinary tract infections, right? We're a female, because of our anatomy, we're more prone to UTIs. Race, for some different types of diseases, you may have more natural barrier to, and then your overall health. Physical barriers, how does your body protect itself? So like, do you have intact skin? Are your mucous membranes intact? Stuff like that. If we have good physical barriers and we take care of our skin and we have good nutrition, that will also help with the natural immunity. A natural immunity does not produce an immune response, and it can't be transferred. This is just for you, for that individual. It's not something that we can give to like a mother that's carrying a child, or we can't give like bone marrow, and this type of immunity cannot get transferred on. This is just your natural immunity. Adaptive immunity. This is active or passive, so it's natural or artificial. Active immunity is where the body actively responds with antibodies. So naturally active immunity is your most effective and longest acting, okay? Remember that, okay? This is a good thing. Natural active immunity is your most effective and longest acting. It is produced by the individual after developing the disease. The plasma memory cells will respond, results in protection from that disease at a later date. So this could be, again, like even measles or mumps, God forbid you had something like that. But if you get the measles or the mumps, you will obtain, hopefully, that natural active immunity. And again, that's your most effective and it's the longest acting. Okay, so just make sure you do know that. Artificial active immunity is when we get an immunization. How many immunizations do we need to get to go into nursing school, right? And to work as a nurse. So it's your immunization or vaccination. These immunizations or vaccinations are incapable of causing a disease, but the body responds to the organism and antibodies develop against that antigen. So you're not going to get sick when you get an immunization or vaccination. Okay, that is just a coincidence if you hear this. I hear all the time, oh, I got the flu shot, then I got the flu. Okay, it does not cause the flu to happen. So just know that. Immunization or vaccinations are incapable of causing the disease, but the body responds to the organism and the antibodies develop against the antigen. Protection can last years or a lifetime with either. It depends. It could just be a year, like our flu shot, right? Because it is an evolving organism that's going on, so they will change the type of vaccine that we get. You may also need a booster immunization. So this is good for you to know when we're on Med-Surg, that the elderly are usually required a booster immunization due to a higher risk of acquiring infections. So just because I got an immunization when I was 4 doesn't mean that it's still going to be good when I'm 60. Okay, so you may need a booster immunization, especially if the elderly, due to a higher risk of acquiring infections. Okay, so that's just an important thing to put in the back of your head also, because again, majority of us are going to be taking care of elderly patients at some point in our career. Passive immunity does not involve individual immune response. This is actually a transfer. So a naturally passive immunity is where the fetus receives the mom's antibodies via the placenta, and it can protect the infant for several months. Artificially passive immunity is artificially donated antibodies such as gamma globulin, antivenom, a rabies vaccine. Protection is lost once the antibodies are used up, so this can last for weeks to months. So we give artificial passive immunity. Sometimes even, we think even animals, they've got like antivenom shots. Or if we have someone that was actually bit by a snake, we give them the antibody. So, this does help with that, but the protection is lost once the antibodies are used up. So this is just a shorter time. Usually it only lasts from weeks to months. This slide is just kind of to clarify the processes of immunity versus the 2 immune responses. So you've got your natural immunity, also known as innate, And then you can see you've got your adaptive immunity, which is also active, and then you've got your passive immunity. Okay, so this again, hopefully will just help clarify a little bit of what we just went over. Here is another slide, again, with your acquiring immunity. You've got your natural, your active, and your passive. So take a look at these, just familiarize yourself a little bit, as far as where each of these different immunities come from. So immunizations. An immunization is a live or killed microorganisms that produces artificially active immunity against a specific organism. The purpose is to induce long-lasting protection but not produce the disease, right? So again, if you're getting a flu shot, you're not getting the flu, okay? But it does produce artificially active immunity against that organism. There's different types of immunizations. Inactivated vaccines, it's where the virus is killed. It will not cause the disease. It stimulates a weaker immune response. So example again is that influenza vaccine. It's required yearly, and the immune response deteriorates, so boosters are needed. So again, that's your inactivated vaccines. Live attenuated vaccines. Attenuated is weakened through the processing, and it cannot produce the disease also. So a live attenuated vaccine, examples include your MMR, and then if you get like a flu spray, that's a live attenuated vaccine. And then the last one is toxoids. These toxins are chemically detoxified without loss of causing immune response. So what toxins, are we chemically detoxifying that'll cause an immunization, will help for an immunization is like diphtheria, cholera, tetanus and pertussis are the big ones that you guys probably have, your DTP. Your tetanus and pertussis is included in that along with diphtheria. Now it's kind of nice we can get one injection. So side effects, yes, unfortunately sometimes there are side effects with immunizations. You may have a local reaction where you've got that redness and swelling. If you look at that picture of that little kiddo up on top, they don't have a lot of adipose tissue, so they may have redness and swelling to it. It's recommended to give in the dominant arm. Because you're moving it around more, it will increase absorption due to the movement. Okay, and you can give Tylenol, acetaminophen, to help with these local reactions. Systemic reactions can include a fever, you could have malaise. You could have a syncopal or vasovagal reaction. That's where you faint 5 to 20 minutes after injection. 40% of these syncopal or vasovagal reactions occur between ages 10 to 18. You'll probably learn that in your ped side also. But just know that's why many times when we give an immunization, we have the client either sitting up in bed or sitting down, and we watch them for like 20 minutes after. Even at the flu clinics, we'll give the injection and we'll have them go sit down, and we just keep an eye on them. And after 20 minutes, we say, okay, have a great day. We just want to make sure they're okay. Okay, God forbid you have an anaphylactic reaction. These aren't very common, but if it does, you may see itching, shortness of breath, you'll hear wheezes. Treatment is your epinephrine. It's a 1 to 1,000 0.3 milligram sub-Q dose that you're giving. And then your Benadryl 50 milligrams IM. You usually want to give that in a different arm. Or you'll give the epinephrine actually in the thigh is actually a preferred site for it. And then we would call 911 if this wasn't in the hospital. If we're at a vaccine clinic or something, you definitely would want to get 911 there, especially if you did not have that Epi and Benadryl on hand, because as soon as you recognize this can decline very quickly. So we want to be on top of this. Healthcare providers must report adverse reactions. There's a vaccine events reporting system that does track all of these things. So if there are any kind of adverse reactions, they want to make sure they don't see a trend to where it may be a certain like lot number that they have produced that's causing these things. So procedure for immunizations, patient education, there's a vaccine information sheet. You can look on the CDC, there's handouts. At Tri-City, we do need to give a flu vaccine sheet or pneumococcal are the two main ones that you will give in a hospital. They actually may require consent. I mean, we don't require a consent at Tri-City, but some places do. You're not going to get tested on that, but just know, depending on where they're at, you do actually, they are consenting, but they're not going to be signing an actual consent form like for surgery, right? Because you will ask them, I have a influenza and pneumococcal vaccine. Would you like these? And you would teach them about it. And sometimes the patients will say, no, thank you. And that is their right. But you do need to make sure that they're educated on why it would probably be best for them to receive it, especially our elderly patients. If they had a previous reaction or an egg allergy, you want to be aware of this because they could have a reaction to one of these immunizations, and then follow the vaccine instructions if there's any special instructions on there. When you give an immunization, usually give it on the dominant arm in the deltoid. Okay, so remember, you're going to do 1 to 2 fingers below your acromion process. Give it in the meaty muscle there. Okay, don't go too far down. It's an IM injection. It will document the lot number. That's what's nice is with the scanner, it scans all this information in there, but if not, you will have to physically either write it down or type it in. And when you give an immunization, you need the lot number. You need to observe for 20 to 30 minutes post-injection. And then it is good to have medications available if they possibly have an anaphylactic reaction. Again, it's rare, but it does happen, so it's essential to be ahead of the game than behind if this does occur. All right, guys, we're getting through there. We're almost done, actually. I'm sure your heads are spinning by now. Hypersensitivity reactions is when the immune system overreacts to antigen causing harm to your patient. Okay, in reality, we rarely know a cause at the time of reaction, but knowing enhances the correct remedy. So if there is any kind of excessive immune response to an antigen, it's good to know this. So knowing this, if a hypersensitivity reaction did occur to somebody, we will be very cautious in giving that type of immunization or really any immunization the next time, so we will really want to watch these clients closely. So what are the types of hypersensitivity reactions? Type 1 is a rapid hypersensitivity. Okay, so this is fast. Okay, this is the most common. What happens? You have an increase in your IgE antibody response to the antigen, which will cause acute inflammation. From that acute inflammation, you will have a local or systemic reaction. So they may have an allergy to this. If they have an allergy, it could cause an asthmatic response. Allergic rhinitis. Okay, so this is interesting because you may not actually look at this as a type of allergic reaction, but if somebody suddenly starts complaining of a sore throat, a runny nose, headache, congestion, itchy, watery eyes, then that could be an allergic rhinitis, and that actually is a hypersensitivity reaction. So be aware of that. Okay, and how you can find out if they are having an allergic reaction versus being sick, because if you think you got a sore throat and a stuffy nose and a headache and congestion, you won't have a fever usually with these hypersensitivity reactions. So that can sometimes help you, figure out what is actually going on with this client. They may have some sort of atopic dermatitis where they get like a rash or something to it. They may have an allergy reaction like to some sort of latex. Remember, your avocados, strawberries, bananas, all those types of things can cause sometimes a local or systemic reaction. And again, those are all allergies they may have. So hopefully I didn't confuse you with that. So allergies, asthma can cause it. Sometimes the allergic rhinitis, again, the sore throat, runny nose, headache, congestion, itchy, watery eyes. Again, they usually don't have a fever, so you can usually differentiate that they're not actually just sick. Atopic dermatitis, latex, avocados, strawberries, and bananas. Those are all different types of allergies that could have a local or systemic reaction. Insect bites. If you get bit by a dang mosquito, or something, we'll go more over that in another lecture. Anaphylaxis. It's a reaction to meds. It could be a reaction to shellfish, to IV dye. If an anaphylactic reaction happens, you may develop angioedema. Okay, angioedema is a life-threatening airway obstruction. Okay, you need to get that airway stabilized because angioedema, it's edema of the face and the neck and the tongue and the lips. If you ever saw somebody that had an allergic reaction, that was an anaphylactic reaction that had angioedema, you will never forget what they look, because they look like a blowfish. Okay, they are just blown up, and that does not really look good. It may look kind of funny on them, but you really got to be aware that everything's closing up, and that includes their airway. Okay, so we really need to stabilize an airway. Epinephrine is your drug of choice. Okay, that is your drug of choice to help reduce that anaphylaxis. So if the patient has a fever, look for other signs of infection. They may have yellow discharge from a throat, coughing up green or yellow sputum, many times develop a sinus infection. Again, because you need to really kind of determine if this is an infection or an allergy that they have from a reaction. So yeah, again, we're looking for fever, you're looking for discharge from the throat, green or yellow sputum. Many times that's like a sinus infection that they have obtained, and it's not an allergic rhinitis from a local or systemic reaction. Okay, so there's just two separate things where they may look pretty similar. Collaborative care, you just avoid. If you know what's going to cause this local or systemic reaction, if you had it once, don't go back there again, so avoid it. They may do a desensitization, where it's an increase in the IgG response in small doses. Antihistamines, the main thing you need to know about that you could give antihistamines, especially for these allergies, is you want to make sure that this is actually a fall risk. So you want to have your clients on fall precautions because they can make patients drowsy. I mean, some of us pop antihistamines like candy, I think, just because, if we've got like hay fever and the runny nose and all that type of thing. But if it's something that you're giving and it's new and it's someone that's in the hospital, just be aware they could be they should be a fall precaution because it can make your clients drowsy. Epinephrine. The EpiPen that we see advertised, with I'm sure you've heard it now because, they're saying it's like $600 for an EpiPen, which is ridiculous. But if somebody has an EpiPen and they self-administer themselves with Epi, they still need to go to the ED because there's a risk of the allergic reaction relapsing. The half-life of your epinephrine, your initial dose, may not sometimes last out that allergic reaction. So you'll see someone give themselves an EpiPen, their symptoms will start to improve, but over time they will go back to that allergic response, that anaphylactic response. So just so you know, you want to educate if you're discharging someone with an EpiPen for some sort of allergy and they're worried about this, if they have to use it, they need to go to the ED just so that we can keep an eye on them. Most of the time they're fine, and then they go home after a couple hours, but other times they do have a repeat reaction going on. Other treatments. So here's your nursing interventions. These are important to know also. Steroids like prednisone to reduce your inflammation. You can give an antihistamine. An antihistamine is an example is chlorpheniramine or chlortrimeton. Those are antihistamines. Decongestants, you'll get oral and nasal. Decongestants don't clear the allergen or prevent histamine release. Rather, they vasoconstrict the inflamed tissue, which will reduce the edema to the area. So that's what decongestants do. They don't really get rid of what's going on. They just vasoconstrict that inflamed tissue, and then you have less of the side effects. You want to check your labs. What labs would you want to know in type 1 hypersensitivity reaction? You're looking for an increase in your eosinophil count. The normal eosinophil count is 1 to 2%. So if you see it elevated, that means they probably did have some sort of hypersensitivity reaction. And you also want to check for an increase in white blood cells and neutrophils. Your neutrophil normal count is 55 to 70%. If it's higher, it indicates an acute infection along with rhinitis usually. So you'll see that whole sore throat, runny nose, headache, congestion thing going on. You'll see there's a skin or scratch testing to identify allergens. If you do a skin or scratch testing, let's say you're at a clinic, you want to make sure there's emergency equipment available, because what they're doing is they are doing small scratches on the back, and they are introducing all these different types of environmental and food that could possibly cause a hypersensitivity reaction. If they have an anaphylactic reaction, you want to be able to respond quickly and appropriately. So make sure if you do skin or scratch testing in a clinic, you want to make sure the emergency equipment is available. And then if someone is on the antibiotics for a reason, they need to complete the entire prescription, okay, so that we do not have a reoccurrence of this. All right. Okay, type 2 cytotoxic reactions are mediated by IgG. It's an autoantibodies that attack cells due to the foreign protein that is attached to them. So an example is like a hemolytic transfusion reaction. And in collaborative care is we're just going to discontinue the causative agent, like if it's a drug or if we're giving blood. And then they may need plasmapheresis to remove autoantibodies. Okay, so there's not a lot that you need to know. Just really know that your blood reactions is usually a type 2 cytotoxic reaction. Okay. Type 3 is an immune complex reaction. This is immune complexes form in response to excess antigens, and it will cause tissues and vessel damage. The immune complex deposits in the blood vessel walls. Okay, so connective tissue disorders that you will see immune complex reactions include arthritis, SLE, which is your lupus, systemic lupus erythematosus. And that again causes tissue and vessel damage. So your immune complex deposits in the blood vessel walls, okay, which is not good. This is your type 3 of reactions. So collaborative care, symptomatics, treat the symptoms. Okay, you're going to treat the symptoms, and then you may give immunosuppressants to these types of reactions. There's something that you don't see a lot of, but be aware, something called serum sickness. This occurs after receiving certain drugs like penicillin and some animal serum medications. The immune complexes disperse in the blood vessel walls of the skin, joint, and kidneys. Patients may present with a fever, arthralgia, rash, malaise, enlarged lymph nodes, polyarthritis, and nephritis after 7 to 12 days. So this is something that you're not going to see immediately after. This is due to nephritis, so you want to check the labs for an increased BUN. Your normal BUN is 8 to 23 milligrams per deciliter, and your creatinine is less than 1.3 milligrams per deciliter, and your white blood cells, normal is 5 to 10,000. Okay, so you want to look for an increased BUN, creatinine, and white blood cells due to nephritis. So that is serum sickness. So just be aware, again, penicillin. And then some of the medications we give are actually derived from animals. So it's animal serum medications. It can cause these types of serum sickness reactions. Type 4 is a delayed hypersensitivity reaction. The T cells respond to antigens due to previous exposure. Many times it's a delayed reaction, 1 to 3 days. An example of a type 4 delayed hypersensitivity reaction is contact dermatitis, like you'll see poison ivy. A transplant rejection, that doesn't usually happen right away. It's usually a couple days later. So as a nurse, what do? You want to remove the antigen. The reaction is usually 5 to 7 days. If the reaction is usually 5 to 7 days, you want to treat the symptoms. Okay. You'll treat them with corticosteroids, and you treat to lessen the symptoms. Usually you're just giving a PO corticosteroid like prednisone. You may give anti-inflammatory agents, and then you may give anti-inflammatory agents. Also know that Benadryl, doesn't help type 4 reactions because histamine is not the main mediator in a type 4 delayed hypersensitivity reaction. So, Benadryl we're given more like in a type 1, the allergic reactions that you're seeing there. But type 4, no, Benadryl doesn't help type 4 reactions. The histamine is not your main mediator. And the last one is type 5, which is stimulatory reactions. This is when your autoantibody triggers excessive response by cell surface receptors. So an example of a type 5 stimulatory reaction is Graves' disease. Collaborative care is removal of the specific tissue and to give immunosuppressants. So there's not much you really need to know on that one. For you guys, I would really focus on your type 1, which is your most common, right? That's the rapid hypersensitivity reaction. Know the local or systemic reactions on it, and the collaborative care. What are you going to do as a nurse with that? And then your type 3 reactions, your immune complex reactions, know about that. Review the serum sickness. And then type 4, know your delayed hypersensitivity reactions. What is an example of it, like your poison ivy, contact dermatitis, and then collaborative care for that. All right, guys, I know this was a lot of stuff. Please read the chapter because I think between listening to this and reading, it'll start making more sense. Some of this may have been a review for you because I know we did do some of this in pathophysiology. And that is all we have. So I hope you guys have a great week, and I will see you next week.